If you've got electric pain in your face and your dentist can't find the problem, stop. This could be the single biggest mistake that delays you getting the right diagnosis. Thinking it's your tooth when it's actually your nerve. I'm Dr. Nick Christelis, pain specialist physician in Melbourne and co-founder of Pain Specialists Australia. This practice has seen more than 23,000 patients since its inception 13 years ago. By the end of this video, you'll know exactly how to diagnose trigeminal neuralgia, the different types of trigeminal neuralgia, and how to tell it apart from other causes of facial pain like dental pain, TMJ pain, and how to go about getting the right diagnosis. So let's get on with it. So let's talk about classic trigeminal neuralgia. Essentially, trigeminal neuralgia occurs when a nerve in the face, which we'll get to, misfires. There is a problem with the neural circuitry. It causes sudden electric shocks, bursts of pain in the face. The pain lasts for seconds to minutes, and it can absolutely stop people walking in their tracks. Most people describe it like a lightning striking my face, like touching a live wire, a live nerve. Between attacks, you're completely and utterly pain-free, and that's one of the biggest diagnostic clues of trigeminal neuralgia. In a little while, I'm going to give you a 4-point checklist that you can use to help making the diagnosis of trigeminal neuralgia, which will stop months of seeking the wrong diagnosis. So common triggers of trigeminal neuralgia. This is everyday touch, not infection, that sets it off. So essentially, the pain is usually triggered by very light contact within the distribution of one or more of these trigeminal nerves that is affected. And the distribution means where that trigeminal nerve carries sensation from the face. So the three branches of the trigeminal nerve are V1, which is the ophthalmic branch, V2, which is the maxillary branch, and V3, which is the mandibular branch. And they are very discrete areas of the face that you'll be able to see on the diagram in front of you. V1 above the eye, V2 between the eye and the edge of the mouth, and then V3 from the mouth to the bottom of the jaw. Triggers can be what we call innocuous. They are minor triggers. It can be light touch. It can be wind on your face. It can be brushing your teeth. And that's why people sometimes think it's a dental problem and see the dentist first. But there's generally nothing to see when you look further. There is no infection. There is no redness. The nerve is hypersensitive. The nerve is not inflamed. And this is why trigeminal neuralgia is such a mysterious and invisible problem. Just to give you some statistics, it affects about 0.3% of the population, so a small proportion of the population. It usually affects people in their 50s or older. And one of the things about trigeminal neuralgia, and I say this to people, colleagues, patients all the time, it is absolutely debilitating. And the reason why it's debilitating, and the reason why you're 3 times more likely to have anxiety or depression than the general population, it's because you cannot escape the pain. If you've got a hand pain or arm pain or foot pain or even back pain, you can distance your brain from the pain using distraction techniques and some other things. But when the pain is in your face, you cannot get away from it. And when the pain is so severe, you just cannot get away from it. So it literally stops you in your tracks. And I've had patients that have been walking down the street and they literally fall down because the pain is so severe and excruciating. When you compare trigeminal neuralgia to dental pain or TMJ pain, which is the temporomandibular joint, there are some things that you can gauge to contrast the difference between these two types of pain. And most people start at the dentist, which is fine, because it feels like it's coming from your tooth. And that's okay, but the key is not to spend months, sometimes even years, chasing a dental problem. And I've seen patients that have had dental extractions, root canals, jaw operations, a whole bunch of surgeries, and not only have they not helped, but if you've got neuropathic pain in that area, they can sometimes compound or make the situation even worse. So dental pain is a little different. It's dull, it's throbbing, it's continuous. It does hurt when you bite something or you've got hot or cold sensation in your mouth. And when you see the dentist, they usually find a problem. TMJ pain is different. It's pain in this part of the face. It's more of a deep ache near the ear. It can change with chewing and jaw movements. It can usually affect both sides, not necessarily one side. and it's linked to jaw movement as mentioned. So it's a different kind of pain, whereas trigeminal neuralgia is sudden, stabbing. It lasts for seconds, if that. Sometimes a little longer, but usually seconds, and it's often got those innocuous triggers, as I've mentioned. The thing about trigeminal neuralgia, if the pain disappears between attacks and it isn't tender when you bite, it's probably not your tooth. Keep watching, because I'm going to share with you clues that separate trigeminal neuralgia from almost every other dental pain, and I'm going to dive down into a little more detail in a minute. What I want to do now is I want to get a little technical. I want to show you some pictures on the screen, what we call the diagnostic criteria to make these diagnoses, the diagnosis of trigeminal neuralgia and the various types of trigeminal neuralgia, because there are more than one type of trigeminal neuralgia. So I want to give you this information. So stick with me, please. So I'm going to show you something on the screen, but essentially there are 4 types of trigeminal neuralgia. There is number 1, classical trigeminal neuralgia. Number 2, secondary trigeminal neuralgia. Number 3, idiopathic trigeminal neuralgia. And number 4, painful trigeminal neuropathy. So let's get into each of them. So this is how you diagnose trigeminal neuralgia generally. So any of the types of trigeminal neuralgia. There are 4 checks. Number 1, recurrent paroxysms of unilateral facial pain in the distribution of one or more divisions of the trigeminal nerve with no radiation beyond. So what that means is you get pain in one or more of those 3 areas that the trigeminal nerve is, not out of that area. It doesn't occur in the neck, the arm, the shoulder, anywhere. It's just in that area. Number 1, it's on one side of the face usually. Number 2, the pain has all of the following characteristics. It lasts from a fraction of a second to 2 minutes, no more. It's severe. It is absolutely intense. And it is electric shock, shooting, stabbing, or sharp in quality. And number 3, it is precipitated by what we call innocuous stimuli within that distribution of the nerve. So what that means is light touch in that area can trigger pain. Brushing your teeth can trigger pain. Wind can trigger pain. Putting on makeup can trigger pain. Having a shave can trigger pain. And number 4, there is no other diagnosis to account for it. It's not the TMJ, it's not the tooth, it's not the salivary glands, it's not the neck. There are many causes, which I'm going to show you in a little while. So that is how you diagnose trigeminal neuralgia. That's it. Now let's move on to the types of trigeminal neuralgia. Number 1, classic trigeminal neuralgia. This is 75% of the trigeminal neuralgia. So if you've got trigeminal neuralgia, it's likely to be classic trigeminal neuralgia, just because it occurs in 75% of people. This is where the superior cerebellar artery generally compresses the trigeminal nerve. And there are different types of compression. There's touching, which is not that important because autopsies have shown that I think it was 17% of people at autopsy can have the superior cerebellar artery touching the nerve. They don't have trigeminal neuralgia, never did. It just touches the nerve. But there are degrees of touch, and there is touch, there is indentation and compression. So it's the indentation and compression that is more likely to trigger classic trigeminal neuralgia. So the diagnostic criteria for classic trigeminal neuralgia are as follows. Recurrent paroxysms of unilateral facial pain fulfilling the criteria which I've just mentioned, number 1. Number 2, there is demonstration on MRI of neurovascular compression, which means there is compression of the nerve by the blood vessel, not contact, but actual compression. And number 3, there is no other diagnosis that you can find. Let's move on to secondary trigeminal neuralgia, and that's about 15% of trigeminal neuralgias. Now, secondary trigeminal neuralgia is where there's a documented underlying disease recognized as a cause of the neuralgia that can explain the neuralgia. So what that means is there's a reason for it. And secondary trigeminal neuralgia is not necessarily classic trigeminal neuralgia. So secondary trigeminal neuralgia, because there's a disease going on, which I'll get to, it can happen on both sides. It can happen in people generally younger than 50 years old. And you can get some sensory changes. In other words, when your specialist examines you, you feel numb, you feel hypersensitive in the area, some sensory changes that can be detected. So what are the secondary causes of trigeminal neuralgia? Multiple sclerosis, that's a big one. Tumors in the area are another one. Bone disease in the skull is another one. And there are a whole bunch of other medical conditions that can trigger secondary trigeminal neuralgia. Diabetes, malaria, syphilis, hydrocephalus, arachnoiditis. These are all big medical terms, but nevertheless, your specialist, if you've got these features likely to be secondary trigeminal neuralgia, your specialist will seek a diagnosis. And that's why it's so important, which we'll get to in a little bit, for every person with trigeminal neuralgia to have an appropriate MRI scan. Everyone with trigeminal neuralgia, as I've mentioned, in terms of fitting the diagnosis, needs an MRI scan. That's just it. Because you've got to make sure it's primary, which is the neurovascular compression, or you've got to make sure or confirm there is a reason for the secondary trigeminal neuralgia caused by medical illness, as mentioned. We've done primary, we've done secondary trigeminal neuralgia. Let's move on to number 3, idiopathic. Idiopathic just means we don't know. This is the diagnostic criteria for idiopathic. Unilateral or bilateral, one side or both side, facial pain in the distribution of one or more trigeminal nerves fulfilling the criteria C. In other words, there is no cause that's been identified. And idiopathic trigeminal neuralgia, generally they get what we call sensory changes. So there are some changes when you examine the skin in that area. There is hyperalgesia, allodynia, a brush, toothpick triggers the pain. And sometimes there can even be numb spots in that area as well. So essentially it signifies trigeminal nerve dysfunction. And there's no other cause found. So that's idiopathic trigeminal neuralgia. Let's move on to the 4th type of trigeminal neuralgia, and that's called painful trigeminal neuropathy. What are we talking about here? This is how we diagnose it. Number 1, you can have unilateral or bilateral, one side or both side, pain in the distribution of one or more trigeminal nerves. You see how I'm making a specialist of you already? You know what I'm talking about. Number 2, there is a disorder other than those described above, but known to be able to cause trigeminal neuropathy with clinically evident positive or negative features. So that basically that's a long term for there is a reason for the neuropathy, but the neuropathy is not classic trigeminal neuralgia. There is evidence of causation demonstrated by pain that is localized to the distribution of the trigeminal nerve affected by the disorder, and pain develops after the onset of the disorder or led to its discovery. That's a fancy way of saying there is a reason for the trigeminal nerve being injured that has triggered this trigeminal neuropathy. Neuropathy means dysfunction of nerve. Neuralgia just means pain. But neuropathy means the nerve doesn't work very well. So that might be dental work, sinus procedure, ENT procedure, trauma, and other things. So you've got to find the reason, then you can manage the reason. And of course, you can manage the pain as well, which we'll get to. Let's discuss MRI scans, and I'll show you some MRI scans, but essentially every patient with a diagnosis of trigeminal neuralgia, and now you know how to go about making that diagnosis, needs an MRI scan. You need an MRI scan to confirm that it's classical trigeminal neuralgia, so classic trigeminal neuralgia. So there's microvascular or neurovascular conflict is what we call it. There is not just touching, there's a blood vessel not just touching the nerve, but actually compressing the nerve. You want to look for that actively. Number 2, you want to make sure there are no various other issues that can detrimentally affect the nerve. So an MRI is very important. Your specialist, which we'll come to in a little bit, is going to help you get the appropriate MRI scan, because it's not just MRI scan. You've got to have the appropriate MRI scan to help confirm and diagnose trigeminal neuralgia. Having a head CT scan is not appropriate. It's not going to help you with the diagnosis of trigeminal neuralgia. It might help you with other things, but it's not ideal. You need an MRI scan. A neurologist, a neurosurgeon, a pain specialist can help you get those appropriate scans. The MRI scanning helps confirm why you've got the trigeminal neuralgia, but it's not going to diagnose trigeminal neuralgia. The diagnosis is what we call a clinical diagnosis. That's why you need somebody experienced to assess you. Stick with me because we'll talk about how to go about getting the right diagnosis in a little while. Now, let's talk about red flags and when to be worried, because this is important. And remember, this video is an educational video. Yes, we are experts in the field of pain assessment and pain management. This is what we do. This is all we do. We're good at it. But what I'm giving you now is not medical advice. Of course, this is education and, of course, my opinion. But please use it well. The most important thing is to get the right medical help, which I'll come to. So let's talk about red flags and when to be worried, when to escalate things. Seek medical advice if you're not eating. Seek medical advice if you're not drinking. Seek medical advice if you're losing weight, if you feel like you've got fevers, infections. If the pain becomes continuous and there are no massive gaps, you're going to seek medical advice quickly. If you've got numbness, weakness, if your face is changing shape in any way, you must seek medical advice. If you've got double vision, if your eyes are not working properly, please seek medical advice quickly. If you're not sure how, go to your family doctor. If you're not sure, go to the emergency room. I just want to make sure you understand that there are some worrying signs that are associated with this complaint that signifies something more that's going on. And again, that's why you need an appropriate specialist to assess you, make the right diagnosis, and get you the right appropriate treatment. Another one when to seek help is if first-line medications, if early use of medications are not helping or side effects are severe, don't push through. Make sure you get help. If you're not sure, depending on where you are in the world, please reach out to our clinic. We're here to do our best to help and guide, but of course, go to your family physician first, go to your general practitioner first, and make sure you get the right help. Please let me know what your symptoms are in the discussion below. Please let me know what you're complaining about. Please let me know what you'd like to learn about, if this is an important topic that you'd like to hear more about. So what do you do if you think you've got trigeminal neuralgia and you're not sure how to go about getting the right diagnosis? Make sure you see a family doctor or general practitioner. Depending on the specialist and what you've got access to, the specialists that you could and should see are neurosurgeons, neurologists, and of course, pain specialists. We have the appropriate network, get the right diagnosis. We've got the appropriate network to get the right treatment. Just a little bit about this practice. When patients come to this practice, we pride ourselves on the fact that we listen. We will do our very best to give patients a diagnosis or diagnoses at the first consultation, and generally followed by a full treatment plan of action, which might involve lifestyle changes, might involve allied health approaches, might involve medications, might involve interventions, and of course the advanced pain therapies, and of which surgery is there. It depends on the diagnosis, the person, and of course the issue that we're dealing with. What you can do straight away is start keeping a diary of these pain attacks. So when you go and see your specialist, your GP, you can present to them these attacks, give them the information. The more information you give them, the more information they have and are more likely to make the diagnosis. So keep a pain diary. Go through the checklist that I've mentioned to see if you fit those criteria and which type of trigeminal neuralgia you might fit. Your primary practitioner, neurologist, neurosurgeon, or pain specialist, depending on who they are, will start you off on different medications. If the pain persists and medications don't help or cause side effects, then you escalate to the next therapy and next treatments. We'll talk about treatments in the next video, and that's why I need you to like and subscribe to this channel so that we can get you that next video, which as soon as I'm done with this video, we'll start on the next video. So that's treatments of trigeminal neuralgia, and we'll dive into that in great detail. I wanted to share with you what we call the differential diagnosis of trigeminal neuralgia. Whilst it might sound like trigeminal neuralgia and appear to be trigeminal neuralgia, we still need to confirm that there are no other issues that need diagnosis and addressing. So we call that the differential diagnosis. And this is the differential for trigeminal neuralgia. Dental causes, of course, and as mentioned, that is a different kettle of fish. It's dental pain. There are many different types of dental causes, caries, sensitivity, periodontal disorders, cracked tooth, and the list goes on. And a good dentist will help confirm and treat those causes. There may be TMJ disorders, temporomandibular joint disorders, which is another big differential in trigeminal neuralgia, as mentioned before. There may be some sinus causes. There may be some salivary gland causes. There may be what we call neuropathic pain causes. So neuropathic pain can affect the face, the neck, the spine as well, and mimic trigeminal neuralgia. And some of the neuropathic pain disorders, just to mention a few for completeness: glossopharyngeal neuralgia, post-herpetic neuralgia, which is shingles, zoster, which triggers neuropathic pain, and I've seen quite a lot of those within the face, but it's a different diagnosis. Post-traumatic, so trauma-induced trigeminal neuropathy, atypical odontalgia, burning mouth syndrome, different diagnosis, different assessment, different treatment. And then the other big differential diagnosis for trigeminal neuralgia is what we call trigeminal autonomic cephalalgias, which is a fancy term for specific headaches, headache conditions. And some of these headache conditions might include cluster headaches, hemicrania continua, paroxysmal hemicrania, and something called SUNCT, which is short-lasting unilateral neuralgiform headache attacks. So long-term, but a good neurologist and a good headache specialist will help you exclude those diagnoses in the workup for trigeminal neuralgia. So just to wrap things up, what I need you to do is keep a pain diary. Seek help from your primary physician, a neurologist, a neurosurgeon, or a pain specialist, depending on where you are. Take with them your pain diary. Take with them your detailed history, the notes that you've been keeping, and that'll help them make the right diagnosis. If you're being under a dentist or somebody else for a long time and you haven't got the diagnosis or the treatments haven't helped with the pain, you might have trigeminal neuralgia, so please seek help with some of those specialists that I've mentioned, because a delayed diagnosis can mean sometimes more difficult to treat in the future. With all these pain conditions, you really want to get the diagnosis early. You want to get to the right specialist early. You want to get the right treatment started early, because an earlier treatment means better outcomes. It just does. I also want to give a shout out to the Trigeminal Neurological Association of Australia. I'll put a link in the description below. They're a not-for-profit organisation. You can become a sponsor, you can become a member. They've got groups, they have conferences, and it's a really good resource if you're not sure where to turn. So thanks to the TNAA. In our next video, we will compare the different treatments and we'll go through the different treatment algorithm for trigeminal neuralgia, from medications, of which there are many, to nerve procedures, and of course dive down into microvascular decompression, because essentially if medications are not helpful for classic trigeminal neuralgia, the best treatment, the optimal treatment, is a microvascular decompression, which we'll get to in another video. Share this video as well, because I know there are people out there suffering and struggling and they don't know what to do. If you're suffering and struggling and you don't know what to do, reach out. There'll be some information in the description below. What I'll also do is in the description below, I'll put links to a couple of research articles for you to digest in your own time if you want a little bit more information. I'll also put a couple of links to our website, where we've got some information on trigeminal neuralgia, and our blog article where we've got some information on trigeminal neuralgia, and that is when microvascular decompression fails. I'll see you on the next one.